I think it's time. Good morning and good evening, all the members in the ICC, the webinar. Long time no see. Today, we are so happy to invite Dr. Carol Yi-Hsuan Chen. Dr. Chen is one of our orthodontic faculty in the Chang Memorial Hospital. And in the past 1 year, she has spent 1 year's time in the Netherlands Radboud Medical Center to learn about the 3D simulation in the orthodontic treatment. So she had just been back to our hospital for the further service. Today, the topic is very interesting. She will presenting the limitations of the orthodontic treatment, camouflage or the OGS. So let's welcome Carol. Please.
Hi everybody. Good night and good evening and good morning. Today, I'm going to start the talk of the limitation of orthodontic treatment. Should we choose camouflage treatment or combine with orthognathic surgery? I will first start with the goal of the orthodontics. We will wish to align the teeth and correct the facial proportions. And we'll start from the history as to see the boundary of the tooth movement. Then we will go through some literature review and borderline cases in class 2, class 3, and facial asymmetries, and provide some evidence that should we choose camouflage treatment or should we choose combine with surgical orthognathic treatment. Dr. Engel is the father of the modern orthodontics. He set up an important classification for orthodontics in 1890s. From the pictures, we show that class 1 is the mesobuccal cusp of the upper first molar occludes to the buccal groove of the lower first molar. And class 2 is the mesobuccal cusp of the upper first molar occludes more than 2 millimeter mesial of the buccal groove of the lower first molar. Class 3 is the mesobuccal cusp of the upper molar occludes more than 2 millimeter distal of buccal groove of lower first molar. However, this classification is basically according to the molar, which is the dental part. So no facial bone relationships are considered. Moreover, less attention was focused on the facial proportion and aesthetics. Thus, we have shifted our modern treatment goals from the angle paradigm to the soft tissue paradigm, which is that the goals of the limitations of the modern orthodontic and orthognathic treatments are determined mainly by the soft tissue of the facial face, not by the teeth and the bones. And this increased focus on clinical examination rather than only by the dental cast and cephalometric analysis in the radiographics. It means that the face first, we should consider the face of the soft tissue first, rather than the cephalometric analysis. And how far can we move the teeth? First, we orthodontics should be very familiar with the envelope of the tooth movement. From this picture, we see the outer envelope shows the upper incisor and lower incisor tooth movement combined with orthognathic surgery. And the middle envelope is the orthodontic tooth movement combined with skeletal anchorage. And the inner envelope shows only the orthodontic tooth movement. However, although we have already these numbers, we should keep in mind that there are still other limitations. From the latest study this year showed that we should also consider the physical boundary of maxillar mandibulolingual cortical plates. During anterior retraction by control tipping, maxillary and mandibular plates may act as barrier to tooth movement, effectively limits the amount of tooth movement. Maxillary and mandibular labial cortical plates were remodeled at all root levels to follow tooth movement in 1:1 ratio. However, the maxillary palatal cortical plate was not found to model significantly even through the roots approach the lingual cortical plates. And the mandibular lingual cortical plates were found to lingually retract only at the 25% root level, while the 50, 75, and 100% root level was unchanged. And Dr. Profits proposed a general guideline to indicate which type of cases are suited for orthodontic camouflage treatment and which cases are indicated for surgical orthodontic treatment. Patients who are suffered from orthodontic average or short facial patterns, mild AP jaw discrepancy, crowding less than 4 to 6 millimeters, normal soft tissue features in lips, nose, and chins, and nose transverse skeletal problems are suited for orthodontic camouflage treatment. And patients with long vertical facial patterns, moderate to severe AP discrepancy, crowding more than 4 to 6 millimeters, exaggerate lip, nose, chin features, and transverse skeletal problems should consider OGS treatment. So if you see the cases which fit in the green one, then it should ring a bell to you that it is a more of an OGS cases. So first, let us see about the class 2 cases. In the following cases, will you choose camouflage ortho treatment or combine with OGS treatment? In the systematic review and meta-analysis for difference between class 2 camouflage treatment and OGS combinations concludes that camouflage treatment is an alternative for less lateral convexity patients, and OGS combination was more effective to correct ANB, SMB, mandibular angle, and soft tissue profile, including the nose. A latest German study reported that compared to the OGS treatment, class 2 patients who received pure orthodontic camouflage extraction treatment still resulted in more convex facial profile and less mental labial fold. You can see from the figure that the blue one and the green one indicates both facial convexity, and the yellow triangle represents the mental labial fold. And patients who receive that OGS will improve with less convex facial profile and more obvious mental labial fold and chin projection. First, let us see the first case. This is a 19-year-old skeletal class 2 hyperdivergent facial type with large anterior open bite cases. She was also suffered from bimaxillary protrusion, mild to moderate crowding. Her overbite is -3. Her overjet is 7 millimeters, and she has a bilateral class 2 and class 2 canine and class 1 molar relationships. According to the above general guideline, she fits 2 criteria to the blue ortho camouflage treatment only, and 3 in the green OGS column. So she indeed is in one of the borderline cases. First, we try to recommend the patient to receive OGS treatment to correct both class 2 relationship, skeletal relationship, and anterior open bite. However, the patient and her parents refused surgery, and they choose the camouflage treatment. So we extract 4 premolars, including upper first premolars and lower second premolars. In 2 years of treatment, we achieved harmonious lateral profile, consonant small arc, positive overbite, and proper overjet. bilateral class 1 canine and molar, and good interdigitations. From this superimposition, we see the severe anterior open bite is successfully treated by 0.5 millimeters upper posterior intrusion, upper incisor and lower incisor retraction and dumping with controlled tipping, and mild mandibular plane counterclockwise rotation. However, she still has some weakening due to no skeletal corrections. Orthodontics should also be very careful that class 2 camouflage treatment may resulted in excessive lower incisor proclination and increased mandibular arch length, and therefore negatively influence the anterior arch length ratio and the final canine relationship. In this condition, mild lower anterior interproximal reduction is necessary to help avoiding increase the mandibular anterior arch length. Or otherwise, we should consider combined with orthognathic surgery. Then we'll see the second class 2 case. Take a look at this class 2 case. She has came to our clinic due to still protruded lateral facial profile and mild crowding. We noticed she has received previous orthodontics with 4 bicuspid extraction before, but she still suffered from mandibular retrusion, mild chin, deviate to right side. Right side is class 1 canine and molar, but left side is end-on class 2 molar. And she still have proclined lower anterior teeth, lower left canine blocked out, and lower mild crowding. She was treated with bimaxillary surgery, including the 4-1 osteotomy, BSSO advancement, and genioplasty. Oh, sorry, and we retract proclined lower incisor and achieve improved lateral profile and chin projection, achieve bilateral canine and molar, and good interdigitation. This is her superimposition. The blue one is the pre-op and the red one is the final. You can see the amount of the mandibular protraction and the profile changes. So with the aid of OGS, we could correct the facial proportion and the AP disproportion more thoroughly and achieve a more satisfied face for the patient and achieve a less facial convexity, better chin projection, and larger mental labial fold angle. Then we will see the class 3 cases. In the below 2 cases, would you choose camouflage treatment or OGS cases? From the 2011 Martinez study showed that the initial SNB rather than the SNA is related to the treatment plan decision. And with appraisal, lower incisor inclination and interincisal angle are the most decisive parameters. Patients with camouflage treatment will decrease the normal self-value percentage after treatment from 30% to 28%, while patients with OGS combination will increase the normal self-volumetric value percentage after treatment from 24% to 33%. A latest German study reported that compared to camouflage treatment, class 3 patients with OGS treatment resulted in significant more convex facial and soft tissue lateral profile by decreasing the distance of lips and the E-line after, as well as the lower lip length. So let's take a look at this class 3 cases. This is an 18-year-old class 3 male with normal facial height, divergent facial type, and mild maxillar retrognathism. Mild chin deviation to right side by 2 millimeters, bilateral class 3 canine and molar, anterior crossbite, mild to moderate crowding. According to the Profit's guideline, he fits more criteria in the blue one, which is the orthodontic camouflage treatment, including average facial pattern, crowding less than 4 to 6 millimeters, normal soft tissue features, no transverse skeletal problem. So he was received a camouflage lower premolars extraction. After 2 years of orthodontic treatment, we retract lower incisor and lower lip, mild mandibular clockwise rotation by lower molar extrusion. And after the treatment, we still remain his class 3 lateral profile and mild chin deviations. And we achieve proper overbite, overjet, and good interdigitation and relief crowding. And we go through some determinants of class 3 OGSs. From the literature in 2011 from Zheng, Dr. Zheng, she does a receiver operating characteristics analysis. And for a class 3 malocclusion patients who fits 4 out of 6 measures determines the need of the OGS, including first, overjet, less than 4.73 millimeters. Second, width appraisal, less than 11.18 millimeters. Third, lower incisor to mandibular plane angle, less than 80 degrees. Fourth, maxillary to mandibular length ratio, less than 65.9%, and overbite, less than 0.18 millimeters. Sixth, gonial angle, larger than 120.8 degrees. And in 2018, they also proposed an equation with edge angle and width appraisal. And they proposed that they were able to differentiate between the patients suitable for orthodontic camouflage treatment or surgical treatment. The edge angle is the angle between soft tissue facial plane and harmony line, measuring the upper lip or soft tissue chin position. And they indicate that the successful camouflage treatment, the initial edge angle should more than 10.3 degree, and the width appraisal should more than negative 5.8 millimeters. According to their study, that 81.5% of the patients were properly classified. Then we'll take a look at this class 3 facial asymmetry and anterior open bite cases. Her chin deviation to the right side about 5 millimeters with occlusal plane canting, left side down. And her overbite is negative 2 millimeters, overjet is negative 8 millimeters, bilateral class 3 canine and molar. And she has mild upper and lower crowding. She fulfills to more orthognathic surgical criteria than camouflage treatment, including long vertical facial patterns, severe AP discrepancy, and transverse skeletal problems. So we performed maxillary surgery to her, including mild level 1 advancement, mandibular BSSO setback, and mild counterclockwise rotation and genioplasty. The pre-op is in blue and the finish is in green. So after treatment, we improved her lateral profile, correct the occlusal plane canting, correct dental midline discrepancy, achieve positive overbite and proper overjet, achieve good interdigitations. Then we will come to the last section, which is the facial asymmetry. From the below two pictures of patients that we noticed that the left side is treated by OGS treatment already. But what do you think the right side? Do you think the right side patient should receive ortho treatment only, or she should receive OGS treatment? From the study in 2011, they mentioned that the layperson's perception of facial and dental asymmetry is one, the dental midline is shifted by 2 millimeters. Second, the nose is a deviation by 4 millimeters. Third, the dental midline canting is more than 5 degrees. Fourth, frontal anterior occlusal plane canting is around more than 3 degrees. And fifth, the chin deviations of 6 millimeters or less. Then we will come back to this case again. This 28-year-old patient, actually she has received orthodontic treatment for 3 years, around 10 years ago. And then although we can see that the orthodontist has done a good job in the occlusion, but she still cares about her chin deviation, protruded lips, and mild gummy smile. And she also suffered from right side class 3 canine and molar relationship and left side class 2 canine and molar relationship due to the facial asymmetry skeletal problem. Her chin is deviated to the left side by 6 millimeters and lower midline is shifted to the left by 5 millimeters. So she would like to receive orthognathic surgery treatment to correct facial asymmetry before, and then she can get her lower left first molar implant done after the treatment. So skeletal asymmetry can rarely be compensated. Even though the tooth is well aligned, we should be more cautious with the patients with moderate to severe skeletal asymmetric patients. These patients are received by maxillary orthognathic surgery, including LaFor-1 and BSSO along with genioplasty. We correct the skeletal asymmetry. This patient is finally happy. She is satisfied after surgical orthodontic treatment with a more harmonious lateral profile and facial symmetry, consonant smile arc without a gummy smile, improved chin projection, correct dental midline discrepancy, and good interdigitation. And she's now waiting for the lower left implant. And this concludes my talk. I hope this guideline in the literature review and the shared cases can provide you with more evidence and experience in the decision-making between camouflage treatment or the orthognathic treatment. And the take-home message is that the face actually sets the case, and the orthodontist should try to make the precise diagnosis and treatment planning beforehand, and listen to the patient's chief complaint and will explain the different results with different approaches. I would also like to give special thanks to the following orthodontists and surgeons who involved the present cases. Please feel free to contact me through the email afterwards if you have further opinions. Thank you.
Okay, thank you, Dr. Chen, for your excellent topic today. And we welcome for all your questions now. And you can text your questions in the chat room. Okay, and Carol is available for your questions. I think that first of all, I have my own question for you, Carol. So in the past 1 years, how do you think that you have mentioned the different indications for class 2, class 3, and the facial asymmetry cases, and in different specialty of the patient, different criteria for the camouflage and the OGS. And how do you think in the Chang Memorial Hospital, because you mentioned a lot of literature, in Chang systems, do you believe it or you have it our own the principle in the differentiated the two different treatment, camouflage and the OGS? In your experience, we rather do the OGS or we prefer the orthodontics to some challenging cases? How do you think?
First, I think it will very depends on the patient's requirement. So we should consult with the patients and see what's his or her chief complaint. And through the in these three types of cases, class 2, class 3, and facial asymmetry, I think we should all be very careful about facial asymmetry cases. That most facial asymmetry cases will need surgical orthognathic surgeries. If the patients, although the patients may say that, oh, I don't think I need it, but after the alignment of the tooth, the patients will find that the face will be more skewed or deviated, and they will realize that how much they need for the orthognathic surgeries in the facial asymmetry cases. So I think we should consult with the patients beforehand and then inform that the patients that the need of the orthognathic surgery in the OGS cases. And in class 2 and class 3 cases, for the orthodontic camouflage treatment, mainly we're like rotating the mandible clockwise or counterclockwise to camouflage the skeletal AP discrepancy. So we should also inform the patient about the class 2 and class 3 camouflage treatment, and show them that after the treatment, for example, for the class 2 cases, the chin will not move forward. So actually it's the upper lip retraction and there was still a weak chin. If the patients cannot accept this profile, then the patient should receive orthognathic surgery. And in class 3 cases, we're mostly clockwise rotating the mandible. So after the camouflage treatment, the patient might have a longer lower anterior face. So the patient should also be noticed about this, the profile change. If the patient cannot accept this changes, then he or she may need the orthognathic surgery. This is my personal experience.
Okay, thank you. We have one question from Dr. Clement Lins. He said, it is amazing to see the open bite case using orthodontic treatment. Is there any screwing criteria for an open bite patient to go for orthodontics only treatment?
Excuse me, the growing criteria or?
Screwing. Yeah. Oh no, screening criteria.
Oh, okay.
Yeah. Sorry.
Anterior open bite etiology comes from dental, skeletal, and habits. And in the cases we show in this presentation, she has combined dental and skeletal etiology, including that her upper incisor and lower incisor are proclined, and her yes, and the skeletal part of the anterior open bite is she has a very high mandibular plane angle. So I think the both sides, she still have so when we correct the anterior open bite, we first need to intrude the upper posterior molars, and then 1 millimeter upper posterior intrusion that we can correct a 2 millimeters open bite. So it's 1:2 ratio. And then second is that this patient has suffered from the bimaxillary protrusion. So we retract the upper incisors and lower incisors. So that this also helps to close the bite. And third, we mildly intrude the upper molars. So the mandible is mildly counterclockwise rotation. And this also helps to close the anterior bites and anterior open bites. Yeah, I think this is the 3 reasons that this cases was success.
Okay. Thank you, Dr. Chen. One more questions. May I know if you use mini screw in the anterior open bite case?
Yes, I think mini screw will help. And yes, and in this cases, actually in the first, we will inform the patients that we might use the mini screw. But in this cases, luckily with maxillary TPA, and she got some intrusion of the maxillary molars, and then we got a good rotation of the counterclockwise rotation of the mandible and close the bites. So we didn't use the mini screws at the end. But I think most cases of severe anterior open bite, we should consider using mini screws for the molar intrusion. And from the literature review, if we use with the aid of mini screw, we can intrude the upper molars to around 3 to 4 millimeters. So 2 to 3, sorry, it's 2 to 3 millimeters. And that will help to close the anterior open bite to around 6 millimeters. So it really helps.
Okay, yes. Okay, one more question. Dr. Maria has one question. She says it's a wonderful presentation for you. And she wants to know about the satisfaction rate between the 2 groups in your patients. Which one is better?
Yeah, I think it's a difficult one, yes, to make the patient satisfied by the treatment. And I think if the patient's perception for her problems at the very beginning, and she has expect what is her profile will change after the surgery, after the treatment, not only the orthognathic surgery and also the orthodontic treatment, they will be more satisfied with the treatment result. So I think communication is more important, is also important. Yeah, and in both treatment results, if they are happy, they are well explained and well informed, I think the both satisfaction rate are also very high.
Yes, very good answer. And Dr. Lin has another question about the condyle conditions. Is the condyle condition is an important contributor to the outcome of the open bite treatment?
Yes, I think condyle condition is also a very determining factor for anterior open bite cases. And we should also screen for the condyle condition beforehand. So for the last cases, sorry, I should show the cases. The asymmetric cases and the anterior open bite cases, actually we have done the condyle evaluation beforehand, so she can and then we will treat if the condyle condition is in a stable condition, then we'll go through the orthodontic treatment or OGS treatment. Otherwise, we might exaggerate her condyle condition. Yeah.
Right. And is any differences in terms of the stability between in the two groups, Camouflage and the OGS patient? The stability, yeah.
Yes, if the patient with moderate skeletal discrepancy, if she received OGS treatment, then I think OGS treatment will be more stable than the Camouflage treatment. And in most class 2 cases, severe class 2 cases, if we do a Camouflage treatment and then we followed the patient for around 5 to 10 years, and sometimes we'll see their condyle, will have anterior open contact afterwards. It means that the Camouflage treatment is not that stable, and the stability is not so good. So I think combined with orthognathic surgery is more stable.
Okay, and we have the next one, Dr. Manish. Her question is what kind of the retainer you prefer for orthodontic treatment in your cases, and for how long?
Yeah, stability is a good question, and then retainer is also a good question. Nowadays, we think that most cases will require four lifetimes retention, which means that the patient might need to wear the removable retainers at night for his or her lifelong time. And then we will provide fixed retainers if possible. And according and to the anterior open pied cases, if the patients have the habitual tongue thrust problem, then we might need a tongue crib in the removable retainers to keep her tongue away from the tooth and to maintain the stability of correction of anterior open bite. I hope that answers her question.
Yes, and we proceed to the next questions. Yeah, just like Carol, you as an orthodontist, sometimes it's difficult to convince a patient to come for pure orthodontic treatment and to shift to the surgical orthodontics. So do you have any tips about how to communicate with those patients?
I think in this era, 3D simulation is one of the aid that you can show the patients with this kind of simulation. The patient can see that what might changes after the surgery or after the orthodontic treatment. And the patient will realize afterwards what does she or he really wants. And I think it's a good tool for the communications. Yes.
Yeah. Okay, good. From the Dr. Raja, her question is, thank you for your wonderful cases. And how do you consider about OSA, the problem in camouflage orthodontic treatment for the OSA patient?
Yes, I think in the camouflage orthodontic treatment, first, if the patients we notice OSA at before in the initial, then maybe will not consider retraction, upper and lower lip retraction treatment, because it will narrow down the oral space and might also decrease the airway. But if the patient has no symptom sign beforehand, we should consider it, and we should not over retract upper incisor and lower incisor, and we should maintain a adequate facial convexity for the patient, so that the patient might not suffer from OSA after mid-age or afterwards. Yes.
Yes, one more question for Carol. Do you have any different indication for the choices in the two different treatment in the young group and the elderly group?
Do you mean by should we wait for OGS treatment in young cases, or should we do some growth modifications? I'm not so sure for the question.
Yeah. As for currently, some patients come for the OGS, actually their age is already probably age 30 or even 40s. So in your maybe in inclusion criteria for the camouflage patients, the patient will come to for you do the OGS. So I just wondering why is the different for you to give the different choice based on the different age. Yes.
Oh, okay. If the patient is more elderly, then we should consider that we do not retract too much of the lateral profile, because if we decrease the lateral facial profile, then the patient might seem more elderly than her age. So the patient might complain about this. So we should also notify the patients that how much retraction will do, and we should be very careful about it, because no patient wants to be seen elder than in her age. Yes, and if the patients in the elder age who is receiving OGS, we should also be notified that some patients with especially high social conditions, she might or he might not want to change her lateral profile to prominence. So we should communicate with the patients and make the change subtle but fits to her requirement. Yes, and then I think it is the most important thing.
Yes. Okay. And the last one questions, Dr. Zhou is asking which educational simulations the video do you use to maybe educate or persuade OGS cases?
I'm not using the commercial 3D simulation cases. I'm using my own case patients photos or simulations before, and to show the patients what might change or affect after the OGS treatment. And then if the patient is really hesitate about the treatment and they're willing to have combing CT filming, then we might take a pre-op combing CT film and do the 3D OGS treatment simulation for her, and then she can see that with the this kind of movement, her profile could change. For example, that the facial asymmetry cases, how much the symmetry can we achieve? Sometimes the mandibular border is different, and and the volume of the soft tissue is also different. So in the symmetry, some very severe cases, we might not be able to achieve 100% of symmetry after OGS, maybe 80 to 90%. And then we can show through the simulation that 3D simulation that which kind of asymmetric points we can achieve, but which kind of asymmetry we cannot resolve. And patients should be aware of this treatment effect beforehand.
Okay, thank you. Okay, do all the members or the audience has further questions you want to ask in Dr. Carol? Yeah, thank you, Carol. Long time no see. Yeah, we miss you for the past 1 year. Yes. How was it in Netherlands?
Yes, last year I went to Netherlands in March. So it's like the most severe situation in the COVID last year. So I got locked down in the Netherlands for around 3 months. And then I started the hospital works.
Yes.
Yes. And then when I'm coming back to Taiwan recently, and it's going to a severe lockdown recently. Another lockdown, yes. I'm familiar with lockdown now, yes.
Yeah, so I think you have experience to do how to tide over the lockdown times.
Yeah.
Okay. Thank you, Carol. Thank you for your excellent speech. Yeah, we enjoy it a lot. And we hope in the future we have the opportunity to invite you again, okay, to share more your opinion with us. Yes.
Thank you.
Okay, so I have to announce our next meeting in the ICC webinar. 2 weeks later, at the 6th June, the night of the event, the mornings, we invited the Dr. Akira Yamada. Dr. Akira Yamada, he will give us an excellent talk. His topic is the craniofacial surgery and the microtia reconstruction. And he will share his experience to learn from the two masters. So the two masters, the one is the Dr. Kansayat, and another one is Dr. Nagadas. So I believe that one is a very interesting and a very comprehensive meeting then. So welcome for all your participation that time. And once again, we have to give a big applause to the Dr. Carol Chen again, and see you next time. Good night and good evening.
Thank you.
Thank you. Terima kasih. 谢谢Yi-Hsuan. Very good. Okay. Bye bye. Thank you. See you next time.